I'm so happy to see you all here today. Hello, everyone. Thank you so much for joining us for Demythologizing COVID-19. My name is Sharon Danks, and I'm the director of a national nonprofit organization called Green Schoolyards America, based in Berkeley, California. And I'm also the coordinator of the National COVID-19 Outdoor Learning Initiative. We're here today to talk about how to use outdoor spaces on school grounds as an asset to control viral transmission and vastly improve equitable access to meaningful and engaging learning experiences for students. We know that the national health guidance has been confusing over the last 6 months, and that there's not been much information available so far that relates specifically to outdoor learning environments. This session is intended to address questions that schools and districts around the country have sent us about how to use and manage outdoor classrooms and school programs as they reopen for in-person learning during the pandemic. We'll also have some time at the end of our meeting to take questions from the audience. We wanted to let you know that we're recording the meeting today, and we'll be posting it on our website to share the information. We ask that everyone please keep yourselves muted through the session, and we encourage you to ask any questions that you have for our speakers in the chat box. We'll begin today with some background about the National COVID-19 Outdoor Learning Initiative. I'll frame the rationale for taking learning outside during the pandemic, something that we also recommend in more normal times. And we'll let you tell you a little bit about the resources that the National Initiative is producing that you can use at your own schools to help you move learning outdoors where you are. We're thrilled to have two medical experts here with us for this session, Dr. Nooshin Razani and Dr. Djavaherian. Our speakers will each spend some time sharing their research and medical knowledge with us. They'll give us background on the health benefits of being outside at school and help us understand how the virus is transmitted, and also recommend best practices for reducing risk when schools reopen. They'll also discuss key elements that make COVID health protocols most effective for schools. And after they've had a chance for each of them to speak, we'll move into a Q&A format, and we'll address additional questions that were posed in advance, as well as questions from the audience today that are asked using the chat feature. The National COVID-19 Outdoor Learning Initiative was founded in May 2020 by Green Schoolyards America, the Lawrence Hall of Science, San Mateo County Office of Education, and 10 Strands. It now has grown to include more than 15 other partner organizations and hundreds of participating volunteers across the country. The National COVID-19 Outdoor Learning Initiative supports schools and districts around the country in their efforts to reopen safely and equitably using outdoor spaces as strategic, cost-effective tools to maximize the number of students who can safely return to campus. It seeks to equitably improve learning, mental and physical health, and happiness for children and adults times during the pandemic. So why is it so hard to open schools again? Physical distancing requirements mean that kids would need to be 6 feet apart inside, and most of our school buildings were not built with enough space for that. And most of our school buildings were also not built with ventilation systems indoors that are able to filter pandemic viruses. Sorry. We know that last spring, the online learning program, despite best efforts of school districts, was devastating for many students. The closures left a lot of students without a safe, stable place to go, and it exacerbated inequalities faced by the most vulnerable students. And because many students never logged on, learning loss was widespread, and the pandemic itself is also causing stress and trauma and social isolation, producing a mental health crisis for children and adults. And we know also that everyone has been sitting more and moving less, so it's also a physical health problem as well. And the solution we're proposing, moving learning outdoors, has many benefits. We know that if you take learning outside, there's fresh air, which greatly reduces the risk of transmission. There's increased meeting space for classes, so more students can return more of the time, more spread out, with more mobility once they're in place. Outdoor seating areas can be placed in locations where there are hands-on learning resources nearby. Being outside improves access to nature, which has therapeutic mental health benefits, such as reducing stress and restoring children's ability to pay attention. We also know that greening school grounds in general supports social emotional well-being when it includes places for kids to play and places for relaxation and collaboration, and also places to learn social skills that lead to things like autonomy and confidence and healthy relationships. We know also that greening school grounds builds ecological resilience for the neighborhoods by adding wildlife habitat, shade that cools the microclimate for children, and when we're able, and for long-term projects, asphalt removal, which lets rain soak into the ground. The national initiative builds on existing outdoor learning, green schoolyard, and school garden movements in the United States that have been growing steadily over the last 30 years and gaining momentum over the last decade. Over the last 3 months, we've been witnessing this movement to take children outside hit its tipping point as more schools and districts consider taking learning outside in response to COVID-19. And we know that this approach is incredibly useful as a way to keep schools in session during the pandemic, and that it will also have great value to children and their communities in more normal times in the years to come. So investments made now will reap ongoing benefits. We believe this solution to be one that's useful at any scale. It could be that individual teachers decide to take their classes outside to read a book under a tree, or that entire schools and districts plan all of their classes and programs outside or anywhere in between. We think it's suitable not only for outdoor classroom instruction, but also for PE and recess, lunch and other meals, having specialty programs like library and art and music and garden, and also before and after school programs outside. So our strategy overall as a national initiative is to reframe outdoor learning as the new Plan A and consider online and outdoor options as Plan B. When conditions aren't suitable, you can always go online or inside as backup plans. Our goal is to help schools and districts create plans to move as many classes and programs outside as possible into their school grounds, local parks, and even closed streets. We recommend that schools use low-cost materials to create outdoor classrooms, that they invest in permanent items for long-term use if they're planning to keep learning outside for the long term, and that they plan ahead for local weather conditions if it's too hot, too rainy, too snowy, too windy. There are ways to make the environment more comfortable in many conditions. Overall, this initiative is one that's focused on prioritizing equity. We're trying to help schools return as many students as possible to campus where they can access a safe and stable environment to connect with school resources most effectively. If and when schools reopen gradually, because we know it's hard for every school to open its doors to every student right away, we're hoping that they'll prioritize the most vulnerable students with the highest needs first to be back in in-person learning. We recommend that the whole school community be involved in decision-making and implementation processes for outdoor learning, and provide outdoor clothing along with infrastructure to ensure that all students are equally warm and dry as seasons shift. To accomplish this, this task of helping schools and districts around the country build outdoor learning programs, we've started 10 working groups that are in the process of developing an online how-to manual that when it's finished in the next 4 to 6 weeks, we'll have a full range of materials on how the logistics of how to take learning outside. This session today came about because a lot of the work that's in progress has come across health questions, and we're hoping to get some of the health questions answered so that we'll be able to provide better information in our materials, and you all who are working on this in your own school communities will be able to put things into practice right away. In addition to having 10 working groups that are writing how-to materials, we also have an 11th working group that's a community of practice. It's a place for schools and districts to come and meet every other Tuesday to talk to one another about the work they're doing, and we invite you to join us in that. The online resources are posted on our website. The link is below, and some of the materials are already online, and we'll be adding more in the weeks to come. So with that, I'd like to introduce our first speaker, Dr. Nooshin Razani, who founded and directs the Center for Nature and Health at the University of California at San Francisco, where she's an associate adjunct professor of epidemiology and biostatistics and pediatrics. Dr. Razani is currently conducting a review of outdoor transmission of respiratory virus infections, including COVID, and runs a nature prescription program which facilitates outdoor experiences for stress relief and well-being amongst low-income families. She attended UCSF Medical School, Harvard School of Public Health, and has completed a pediatric infectious diseases fellowship at UCSF Benioff Children's Hospital, Oakland, and an NIMH fellowship in HIV prevention at UCSF. She was awarded an Agents of Change Award by Diablo magazine in 2020. I'd like to welcome Dr. Razani, who will give us an overview of the health benefits of taking children outside, and will summarize what the research tells us about the general principles of COVID transmission to answer some of the questions that schools and districts have asked us. And after she speaks, I'll introduce Dr. Djavaherian. So with that, welcome, Dr. Razani.
Thank you so much, Sharon. I'm coming to this as a researcher and a professor of nature and health, which is a pretty cool thing to be, but more importantly, also as a parent. And I want to really appreciate what you've been doing and to really acknowledge that parents, staff, teachers, we're really in this all together. My area of research is the outdoors and health. And so I'm going to first present some data on why being outdoors in general is good for health. And then to add to that, the new information that's coming out about how being outdoors can actually help reduce transmission of COVID, in addition to increasing equity and access to learning and access to infection control measures.
I'm going to go through the health benefits of nature slides quickly, but you will have them in order to advocate for how being outdoors can help in general. So just being out of doors increases the amount of physical activity that youth have. By 27 minutes a week, it decreases the prevalence of overweight and increases the likelihood that children will be physically active. And as you know, there's a ton of data on how physical activity actually improves mortality and the risk of dying from some of the major illnesses in the United States. The benefits to being outdoors in a natural environment include emotional improvements compared to doing the same physical activity indoors, for example, in addition to the encouragement of developmental milestones, which can range from fine motor skills to things like executive function. In addition, when you look across a population, living near green actually reduces mortality, and that's at every income level. There's evidence that living near green can reduce health inequities, mostly by reducing cardiovascular disease and improving air quality. And we'll talk about that a little bit later in the context of COVID. But having access to fresh air can actually improve how long you live, and it can improve a whole bunch of other things like birth weight and head circumference in newborns. Access to sunshine can improve vitamin D, sleep, and depression. And access to the outdoors can also help improve relationships and improve social isolation, as Sharon mentioned. And relationships are incredibly protective for health. Social integration has a dose-dependent protective effect on health. And for children, even a single relationship is powerful. And caregivers act as a buffer against stress. And so I'm sure there's a lot of youth that are missing their teachers and those relationships at this time. A lot of the research on nature and health has to do with stress and stress regulation. And being in a natural environment can reduce your cortisol and pulse and blood pressure, and over a long exposure time can actually have big impacts, like in terms of anxiety, hypertension, and even the, things like preterm labor. So across the lifespan, and you guys can have access to this slide, those four things: access to physical activity, fresh air, sunshine, and social interaction, lead to a whole host of benefits just for being outside in nature. Those benefits can be to a person, but also to a community. So that was the fast version of why nature is good for health. So I always knew, and we always knew, that being outdoors and being in natural environments can help prevent chronic illness. But we have now learned that being outdoors can also help prevent infectious diseases, and specifically can help mitigate the spread of SARS-CoV-2. And in the next section of my presentation, I'm going to give you a framework by which to understand how the outdoors can help. And then Dr. Djavaherian will give more specific guidelines on prevention using the outdoors. So the predominant theory of how COVID is spread is that it spreads through respiratory droplets and through contact. And I'm going to go through both of those modes. The predominant form of transmission is through respiratory droplets. And so this occurs in 3 steps. The first is that the virus has to leave somebody's nose and mouth through coughing, sneezing, singing. Then it has to survive a flight through air. And then it has to land on a person's face, an unprotected face of a susceptible person. And it needs to land in the eyes, the nose, or the mouth. The good news is that there's actually a lot of ways that we can protect against respiratory spread. So the first thing is to minimize exposure, or to minimize, in a school setting, to minimize the virus from coming into the school at all. And this is where you get some of the regulations about delayed school opening until the number of cases are down in the community. This is the section that I believe Dr. Djavaherian will talk about a lot, things that we can do to reduce the virus from coming in at all. And then once it's in the school, to make sure that it interacts with as few people as possible through cohorting and other measures. The next thing that we can do, the second box, is if the virus gets in, there are things we can do to keep it basically away from our face. And this is where the outdoors really comes in. The third box is if the virus is headed in a direct trajectory towards your face or towards someone's face. This is really about creating barriers for it to avoid your eyes, nose, and mouth. So how does being outdoors stop respiratory transmission in this second box? The first, which is super important, is that it allows for increased distance between people. And so we know that a respiratory droplet travels at least 3 feet, up to 6 feet if you're singing or having heavy exertion or breathing heavily. That can go up to 15 feet. And so just being outdoors increases the opportunity for distance so that those droplets are not coming towards your face. It also may decrease the duration that you're standing next to someone within 6 feet. And then the second way that it can help is by increasing ventilation. So many of these studies that they've done on respiratory droplets leaving someone's mouth or nose and traveling across air happen in closed settings. And so the 15-minute guideline that we have comes from a study where they look at someone expelling, coughing, and they notice that the respiratory droplets stay suspended in air for 14 to 15 minutes. But once you introduce a fan or airflow, then that dramatically decreases, and the chances of it spreading to the next person are much lower. There was an article this morning in the Washington Post, or Wall Street Journal, sorry, that talks about the importance of ventilation indoors and has all kinds of guidelines for schools in terms of how to increase airflow. So a school can do all that, or they can go outside. And so basically outside there is no recirculated air. In addition to the fact that the air is just flowing, the conditions outdoors also decrease the chance of that droplet traveling across the air and hitting another person in the face. And so high temperatures, and I've read around 77 degrees Fahrenheit, higher humidity, very high humidity, and sunlight reduce droplet spread even further. So cooler, dry, low natural light, and low ventilation situations encourage the spread of respiratory droplets. So that first mode of transmission, which is the respiratory spread, is the predominant mode. So just increasing distance between people and having airflow is a huge step. But even if that doesn't happen, there are ways that we can stop the virus from the second mode of transmission, which is by contact. And so basically contact transmission is what happens when the virus leaves the body, comes onto an object. The object then has to be handled by somebody's hand, and then that hand has to come onto the face and to touch the eyes, the nose, or the mouth. Now, there are many ways that we can reduce contact transmission. So first, we can reduce contact with objects that might have the virus on them. And this goes back again to the idea of reducing the virus's chance from entering the school at all. And I won't go into the details of this. The second box is if the virus enters a school setting, is on somebody's hand or nose, and gets on an object, we can limit the survivability or the viability of that virus on that object. And here again is where the outdoors come in, and I'll go through that. The third box shows that then, really importantly, if the virus happens to get into the school and happens to be on an object, then we can reduce the chances that a person or a child will touch that object, and then fourth step, which is really important, take their hand and put it on their face and touch their eyes, nose, or mouth. So the survivability of the SARS-CoV-2 virus depends on the surface. It tends to be sticky and lasts longer on steel and plastic, where it can survive for up to 72 hours, although in the first 12 hours, the survivability really drops off. The more porous the material, the more the survivability decreases. So cardboard, for example, decreases more quickly in 4 to 8 hours, although you can still find virus after that. Being outdoors decreases the virus survivability on surfaces. So first of all, the SARS-CoV-2 virus is an enveloped virus, which means that it actually takes our cell membranes off of it when it reproduces. And that cell membrane is really easily disruptible. So it's very easy to kill the coronavirus with just your general detergents, soaps, 60 to 80% alcohol, or bleach. In addition, the virus is very sensitive to temperature. So there's a 10-fold survival decrease with just 5 degrees change in temperature. And just 30 minutes of 75-degree heat can kill the virus. Sunlight, which can be simulated through UV, has an estimated 10-fold decrease in survival of the virus just after 2 to 3 hours of direct sunlight. So I wanted to mention that one of the reasons why I liked this framework of thinking is that it shows that you can have many redundancies in your efforts to reduce viral transmission. And in settings where resources are scarce, or you really have to make hard decisions on where money is spent, it's important to know that stopping any one of these steps will stop transmission of the virus. And so whereas it may take a lot of resources to cleanse or disinfect or think about how to stop the virus from surviving on an object, focusing on stopping children from touching that object or making sure that everyone in a school setting is really well instructed on hand washing, not touching the face, and mask wearing can also stop the spread of the virus. So I know that next we're going to go into more details on creating a protocol that can create reinforcing levels of prevention. But our group was looking at, okay, there's this theoretical decreased risk of outdoor transmission. Does that really bear out in what we see in epidemiology and in cases? And we've done a review of every reported case of COVID, and we've seen that less than 1% of them were reported to have occurred, have a transmission that occurred outdoors. As an example, in a study that summarized about 7,000 cases that happened in China, less than 1% of them were thought to be transmitted outdoors. So that was actually one single transmission that happened during a conversation in an outdoor location that resulted in one more case. And then there is currently a live database of all transmissions where people are just entering outbreaks as they happen. And right now there are 201 transmission clusters entered into that database, and only 4 of them so far are reported to have happened outdoors. In a study of all work-related infections in 6 Asian countries, only 4 of the 103 infections happened in jobs that were largely outside. So we don't know if the transmission happened indoors or outdoors, but construction work and a few other jobs had lower rates of infection. And then finally, in a study that happened in Japan, the odds of spreading coronavirus were 19 times higher indoors than outdoors. And the odds of super spreading, that means in this case it was spreading it from 1 person to 3 or more people, was 32 times higher indoors than outdoors. So in conclusion, being outside, especially in nature, improves health. It also reduces the transmission of a respiratory virus through the opportunity for distance and ventilation. And it also reduces contact transmission through decreased survival on surfaces. And with that, I will turn it back over to Sharon.
Wow. Thank you so much, Dr. Razani, for that incredibly helpful presentation. It's so reassuring to hear how the virus transmission can be reduced and what the data tell us. Thank you so much for sharing your insights and your perspective on this important topic. Now I'd like to welcome our next speaker, Dr. Cesar Djavaherian. Dr. Cesar Djavaherian is the co-founder and medical director at Carbon Health, and under his direction, Carbon Health has performed 200,000 COVID-19 tests, worked with city and county governments to identify asymptomatic carriers, open source published the largest data set on coronavirus infections, and has advised dozens of institutions on their reopening plans. Dr. Djavaherian is also the founder of Direct Urgent Care, an urgent care network serving the greater San Francisco Bay Area since 2013, and he joined Carbon Health with the merger of Direct Urgent Care in 2018. He began his medical career at the New York Presbyterian Hospital, the University Hospital of Columbia, and the Weill Cornell Medicine, developing clinical skills in emergency medicine and serving as chief resident. He's also served as an instructor and physician lead for the Division of Emergency Medicine at the New York Academy of Medicine, and he received his Bachelor of Science and Master of Science degrees in Biological Sciences at Stanford University and graduated from the University of Rochester School of Medicine and Dentistry. Now I'd like to invite Dr. Djavaherian, who will share with us the research that his company has been doing on COVID and what their findings mean for practical considerations for schools and districts that are trying to reopen. And he'll also share examples of health protocols he's developed to help schools reduce risk of virus transmission as they use and manage their indoor and outdoor spaces. So please join me in welcoming.
Thanks so much, Sharon. Appreciate it. I'm Caesar, emergency medicine trained physician and co-founder of Carbon Health. So Carbon Health is a technology-driven healthcare delivery company. We work to actually not just have physical space, to take care of patients. So in our clinics, we have about 25 across the country. We do telemedicine and virtual care now in all 50 states. And our journey around coronavirus started January 23rd when we had our first patients come into the clinic with fever and tachycardia, and they had recently come from Wuhan City. So we had to learn how to deal with coronavirus at the very earliest stages of this pandemic. And one thing that we did was come up with protocols so that we could actually welcome these potentially infected patients into our space or into our spaces while keeping our providers, our healthcare workers safe. And the protocols that we put together in those early days, so starting in January, which included using technology to risk stratify people. So that's kind of the early days of the symptom tracker. We combined those with in-clinic protocols around hand hygiene, masking, wearing of gloves, and also the assumption that a patient with coronavirus could walk in at any time. And I think that those lessons are important ones, not just for businesses as they reopen across the country, but also for schools in particular. I think that you'll hear from most anyone that you can't bring down the risk of a student or a staff member with coronavirus coming into your space or even into the outdoor space. You can't reduce that risk to zero. And so much of the efforts should really be spent on identifying protocols to keep people safe in case that happens, and functioning as if it could happen any day. We've now worked with dozens of companies with tens of thousands of employees, multiple school systems around the country where we've deployed protocols, and within those schools we've actually experienced outbreaks, meaning a staff member or a student who's tested positive for coronavirus. But luckily, because of our protocols, we've been able to prevent transmission to others in the school. So, and that's, I think, why we feel confident now in talking about this more publicly. As was mentioned before, in our clinic, so beginning in March, we started testing patients for coronavirus. And to date, we've done now over 215,000 tests. And none of our employees have been infected by coronavirus, in that time, which is remarkable because we're really inviting people to come in when they're sick. So we have a higher risk of, a higher prevalence of disease in our space than hopefully your schools do in your space. So I'm not sure if everyone can see my screen or not. Okay. So, so Carbon really is it's like a medical clinic where you can go in for any kind of urgent care, primary care, women's health, mental health need. And during this pandemic, we really focused on what the community needed, which was leadership, direction around coronavirus. We've kind of had to step in where, unfortunately, sometimes local governments or federal government hasn't been able to provide appropriate guidance to businesses, schools, about how to handle this pandemic. So a little bit about us, we again have the benefit of not just having doctors. So this is Dr. Justin Young on on our app, and then Dr. Singh. So we have real physicians, real nurse practitioners, real PAs taking care of real patients, but also using technology to mitigate the risk of taking care of people. So the current state of coronavirus, in the US, we're in a bit of a trough as far as daily cases, about 40,000 new cases per day. Across the US, 900 deaths per day. The case fatality rate is 3.1%. Unfortunately, there are only about 700,000 coronavirus tests being performed per day, which is remarkable that we're starting to reopen businesses and schools when the Harvard School of Public Health has put out a fairly influential paper suggesting that we need a minimum of 5 million tests per day in the US to reopen the economy safely. And our number of, percentage of tests that are positive, it's about 5.8%, and that's relatively high. It means that we're not testing broadly enough or aggressively enough. So, Carbon Health, through our own, learnings around keeping our employees safe, developed a program called COVID Ready. And so we've been working with industries spanning from education to agriculture to technology and professional sports. And we've deployed this kind of multifaceted protocol developed within our company to create many layers of protection around getting people back to work. And in this case, we're talking about education in the outdoor space. The outdoor space, as Dr. Razani was describing, allows you to have one more layer of protection in addition to the protocols that you might have in place. So, what are those protocols in general? So, I think probably most people on this call have now spent quite a bit of time researching different ways of keeping your staff and your teachers safe and your students safe. So these protocols range from a daily check-in with symptoms. So, does your student or teacher have a fever, cough, sore throat, headache, some of those symptoms that might suggest an infection. And if they do, they need to stay home. So coming up with detailed protocols to identify potentially infected individuals early, and marrying that to sometimes if you have the capability, baseline testing to identify any individuals in your system who might be asymptomatic carriers, and then connecting that to a very kind of robust education program. And I think we're going to share with you the education program that we've put in place, really talking about, as Dr. Razani was mentioning, the basics of disease transmission, in addition to good proper hand hygiene, proper mask wearing, and then connecting that as well with access to healthcare. So at least through our program, when we're working with schools, we make it possible for a teacher or a staff member who starts to develop symptoms to very quickly be able to see a doctor through telemedicine through our app, which allows them to figure out whether the sore throat that they woke up with is their allergies acting up, or if it's a symptom that's concerning enough to stay home from work. And then beyond that, what we've done is created a fairly robust symptom tracking or contact tracing protocol. So if someone comes in and tests positive, we can go back and identify potential contacts that they've had within the past 4 to 5 days, which is when they've been infectious before their symptoms developed, and then trace those contacts back to identify additional people who might have symptoms or should be tested aggressively. So I'm going to try to keep this brief, but wanted to talk a little bit about my experience with Golistan, which is our children's school. and the work that they've done in having the students learn outside. And I wanted to highlight Golistan's executive director, Yalda's effort in making this happen appropriately. So the first thing that the school did, which was remarkable, because we've done it with industry, but in the school system, it seemed to be that much more important. But it was to get all the stakeholders in the same room to talk about what was important to them. So you have teachers and staff members who are potentially older, might be at higher risk for complications from COVID, but inviting them into the discussion about, okay, what are your concerns? Can we get experts in to discuss these concerns? So what Yalda did was get a group of providers together. So we had physician support. We also had stakeholders such as teachers. We had parents in the room. She worked very closely with local public health officials to identify the protocols that were in place by the county government. And then we worked together to identify the local, the resources we had. Part of those resources ended up being the wonderful outdoor space that the school afforded, and identifying kind of workflows to be able to, check temperature of students before they walk into the space, to have a safer, again, safety layer of having having students outdoors while they're being taught, and then connecting those to the rest of the COVID Ready program. Again, layering an additional layer of safety on top of what we've already been doing. So I wanted to talk a little bit about some of the misperceptions out there about coronavirus and potentially help alleviate a lot of the fear that might be out there about reopening your schools to students again. So remember that at Carbon, we invite sick people to come into our space, and we've done it, hundreds now, over 200,000 times, and we've done it safely. So number one is to realize that it's possible to have a safe work environment, even at school. And if you can do it outdoor, it's even safer. So there's less of a transmission risk. The virus can't live in sunlight or heat as well it does indoors. The porous surfaces that you encounter outside, again, promote the virus from not lasting for as long as it does indoors. So, it's possible to do with the technology that we have today, even before vaccines are created. And we're able to, publish our protocols to this group, if it would be helpful, to try to get, the best practices out there for you. But the other kind of bit of information I'd love to highlight is that just doing a temperature screen at the front door may not be sufficient. In our own data of over 200,000 patients, we see that the number one symptom is actually headache and followed by body ache. And that's particularly true in the pediatric population. So kids typically start feeling punky. They might start to have, complain of like their bodies hurt. Sometimes they complain of stomach pains. There's a lot of overlap with just general illness in kids. And so having guidelines around when to keep these children at home, will help protect your staff, and your teachers. So I know that we're kind of running late on time, and there's a lot more to this presentation, but I figured I'd give it back to Sharon because I know there are questions out there as well.
Thank you so much, Dr. Djavaherian, for your fantastic presentation. It's so helpful to understand more about the practical considerations to mitigate the risk and to hear about the school-based health protocols. I know a lot of people are interested in that, and they've been lighting up the chat with interest. And so they're asking too about specifically about practical considerations. So I thought we would switch now to a conversation with both of you doctors to see to go into a little bit more depth on really nitty-gritty topics that the group has asked, very specific topics about that I'll just maybe go through one at a time and ask you for your thoughts. And the first is about group size and physical distancing while outside. And the questions we've had are things like, are there differences in what you'd recommend for a group size outside or inside? Should they still be 6 feet apart? Is that counted from nose to nose? You know, how do you know if you're 6 feet apart, I guess? And then like, how does it work to have a pod meet outside? Does it matter by age? Are there different recommendations, things along those lines? So if you could talk first briefly about group size and physical distancing, that would be great. That's a question to both of you, so feel free to jump in.
Would you like, you can go first, Dr. Djavaherian.
Or
do you want me to go first?
Well, so I think, you know, obviously the smaller the group size, the better. There is no absolute here. The farther the distance, the better in general. When you're outside, I think those same parameters hold. But I think, you know, at least we can recommend group sizes of 12 or fewer, but it depends on the age and depends on the space. I think Dr. Razani is the expert on outdoor virus transmission, so I'll let her kind of continue.
I agree. I mean, I think that being outside is an extra layer of protection, but since most of our data is from the indoors, I think it's safest to use those same protocols of 6 feet. And just to remember that if somebody does have a positive test result, you're going to have to, everyone in that cohort will have to quarantine. So what's a realistic number of people to quarantine? The bigger the group, the more, unless Dr. Djavaherian, you can chime in if you don't do quarantine, but it's going to have an impact on everyone in that cohort. And then in terms of age, there is less child-to-child transmission, and children tend to get the illness less in preschool and elementary school. After about age 10, the rate of transmission goes up, and then once you're 17, even higher, and then over 25, even higher. And so middle school and high school are very different than elementary school. And the precautions for children should go up with age, and they tend to act more like adults the older that they are. If that answered that question.
Yeah, that's very helpful. So I'll move on to the next one, which is about details of masking. The set of questions are about, people ask, should children always be masked? For preschoolers, are face shields sufficient? If masks get wet or damp, are they still effective? Does a type of mask matter? Is it okay to take breaks from masks while outside? And then what kind of other PPE should be used for long-term exposure outside? That's kind of the range of masking thoughts. Any of those would be helpful to hear about.
Yeah, so, you know, in general, a mask that gets wet is not thought to be protective. We advocate, actually, this came up in our own kids' school, but we advocate actually universal masking for children and having it part of the curriculum. So if you make hand hygiene, masking, some of the precautions that we're having to take around coronavirus part of the curriculum and peer kind of monitored, it seems to promote proper behavior inside the school system. And you know, I think that's been a successful endeavor for us. I think yesterday on the call, we were talking about how parents had a harder time with it than the kids actually did. Kids seem to accept it more. They seem to tolerate the masking a little bit better than adults do. I don't know, Dr. Razani, if you have thoughts on that as well.
Yeah, in California, the Department of Public Health recommends masking only above age 2. And I think pediatricians in general really, hold empathy and love at the center of the conversation. And definitely if there are children with sensory needs or any other reason to not enforce the mask the whole day, that's another reason why being outside is good, because if that kid takes off the mask or needs a break, then that air won't be recirculated and they can just stay away from people and have a little break from the mask. I do think, like Dr. Djavaherian was saying, I mean, this is really about socializing kids to this being normal. And so as much as families can practice at home and adults um, can really model that behavior, it's especially important because we know that the infection really lives amongst adults. And we want to take care of teachers and staff, and we need to recognize that the adults are the ones that need to really create that barrier and to help us spread the infection. In terms of types of masks, the CDC has a really great page on their website that shows that cloth masks or surgical masks, the really simple ones, are just completely fine. The N95 masks are really meant to protect you from aerosolized virus, which is not really happening in a school setting. And then the masks with valves are meant to protect you from chemical exposures, but they do not limit the amount of virus that leaves your body. And so they're not appropriate for limiting the spread of the infection. And then face shields, like the plastic masks and face shields, they're not porous at all. And so they can stop the virus, but then a lot of the air leaks around them and so you still have a lot of respiratory virus spread from around them. So if there's a child that really can't handle the mask and they need to wear a face shield, then a bandana or anything to try to limit that air from leaving the side is helpful. Dr. Djavaherian, what do you normally recommend in terms of type of mask?
Yeah, so we don't recommend the N95. So just either the surgical mask called an isolation mask, or as you mentioned, I think in the outdoor space you can be a little bit, really any kind of face covering, even if it's cloth, would be sufficient. Yeah, we do. So we treat contacts. So the reason for these protocols has to do with kind of, if someone ends up being positive, how do you deal with it? So the first question we ask is, how long have you been in close contact with the people around you? And so if those numbers are less than 6 feet for more than 15 minutes, and people are unmasked, so that becomes a high-risk exposure. And so the protocols around masking and the timing of masking really has to do with what Dr. Razani was saying earlier, which is, are you willing to quarantine an entire pod? So the more lax these recommendations, these protocols are, the more likely you will be to, in case someone tests positive, to quarantine an entire group. So it could be a classroom for 7 to 14 days. But what we've seen in practice is when these protocols are followed, it's incredibly rare to identify someone with a high-risk exposure, which would be unmasked, less than 6 feet for more than 15 minutes, even amongst schools. So we're not seeing that type of outbreak even in schools, and even in schools where there are predominantly indoor activities being done.
So the face shields, I mean, their use in the medical setting and also outdoors is to protect your eyes and to give an extra layer of protection. And so I think if you can think of layers of protection, being outside is one layer, covering your nose and mouth is one layer, and then covering your eyes is another layer. If a staff person is working with a child who has severe needs and needs to be held or hugged, then you could even argue for wearing a gown and gloves. But I think that each layer that you can afford to do is good. It's okay if there's redundancy in the system. And that just helps prevent heartache and quarantine later on. I also saw in the chat the question about, is 6 feet enough? And I don't know if I forgot if I said it out loud, that singing and heavy exertion does lead to more spread. But again, if you have, as Dr. Djavaherian said, if you have these multiple things that you're doing, do you have different guidelines for singing and heavy exertion, Dr. Djavaherian?
So we do work with production film companies where people are acting and singing and in their faces. So there are many productions that you've probably seen on Netflix or Amazon or Apple. And so in those cases, we just do more frequent testing. So the cohorted environment, the common space becomes, you can't enter it without having a negative test. I think that that's impractical for the school environment, but being outdoors, to your presentation earlier, it sounds like being outdoors will reduce transmission risk even in in that setting. Not sure if I'm getting that question right, but it seems like if people are singing, yelling, and screaming, being outdoors is much safer than being indoors.
Great. But the last question I want to ask is about materials and surfaces, and I know that you already addressed some of it, but people ask specific questions about what do they need to clean outside? Are sandboxes safe to play in? Can kids touch sticks and sand and rocks and logs and things that are in a natural environment that other kids have touched? Should they be segregating their toys within their cohorts? Things, it sounds, and things about sterilization outside, I guess. Just questions on that area.
I mean, I think if you take the framework of really trying to reduce both respiratory, so a lot of the discussion we had was about reducing respiratory spread, and then in terms of reducing contact spread, which is what these basically fomites are, it's still the same principles. The more you can do to create cohorts, and so to reduce mixing, it will help reduce the spread. The CDC has a section on the outdoors and cleaning, and they make it clear that there's a difference between cleaning and disinfecting, and it's very low yield and kind of a waste of resources to disinfect outdoor surfaces like playgrounds and wood. And they even have a section on water and sand and porous materials, which are hard to clean. And so being outdoors can help you clean them, and you may not need to disinfect them, but you still can minimize the chance of getting virus on them that's mixed between pods by cohorting who's using them and when. And so if you have to choose when to clean, and you have a limited capacity to clean, I would do that between times when there's mixing between pods, if that makes sense.
Yeah.
Do you have any input? Yeah.
No, not on that. I totally agree with what you're saying on that. Yeah. I did want to say a few things just looking at some of the questions coming through, and I know that we're running late, but what I would love to say to this group is please, please, please be wary of what you're reading in popular media. And even when you read something that says, kids can't have the virus, or the virus, performs this way in this setting, I would ask that you just take it with a grain of salt. So even like you have Dr. Razani on this call, who's an expert in outdoor transmission. And this virus is so new to us that it's difficult to really come up with exact protocols based in scientific literature on how this virus will behave. But in general, when you pool all the information, as Dr. Razani does in her research, when you pool the data, you come up with a general profile of how this virus behaves and how to keep a safe environment for your schools. The question of, do kids get this virus at the same rate as adults? The answer is Yes, actually, as more and more information comes through, we're realizing that the early data, which were based on hospitalized patients, so right, we saw that very few kids got coronavirus, but that knowledge base came from China, from the early hospitalization data, which showed that very few kids were hospitalized. That turns out to be true, but it doesn't mean that the kids don't get the virus at the same rate as adults do. So as you're hearing more what feels like changing information, be aware that it's based in kind of the novelty of the virus. And you now have some experts around the country, Dr. Razani being one of the most prominent ones, where you can go to for resources and to answer these questions. I mean, looking at some of the questions coming through here, there are multiple misconceptions that would be great for us to all kind of address at some point, including like types of masks, frequency of testing, you name it. I think we've all kind of heard these stories. What happens when a parent tests positive? Does the school come to the, does the student come to school? What do you do? What if the parents end up traveling outside of the area? What do you do as as an institution? We've actually thought through all of these questions. And I think, and I see nodding around, but I think we'd be happy to share these protocols with you. Yeah, so that you can actually start to deploy these protocols in a safe manner for your community. But don't get like take all the knowledge that you're reading about, all the quote experts who say one thing or another, take it with a grain of salt, and try to look for pooled bits of information with large data sets, which are, I think, are showing that this is, that there are safe ways to reopen schools and businesses and the economy. So just going to put that out there.
And I think that what I really take away from that, which is so important, is what Dr. Djavaherian said, that they invite people who have COVID into their space and still try to stay safe. So I think I really like the way you frame this, that you really have to assume that it's coming in. And how do you stay safe anyways? And so when you're making decisions on whether to share toys between pods, you have to kind of make the assumption that one person in each pod may have the virus. So how do you limit it from spreading? I think, and I really appreciate what you're saying about children. And even though children may not show the symptoms, they do absolutely carry the virus.
And then we all have blind spots that we develop from these heuristics. So we read, oh, maybe kids are safer than adults. And so that turns out to be a blind spot. So I think there is a comment about kids under 2 not having to wear masks, or kids not having to wear masks outdoors in California. I think those can be blind spots in your protocols. So the question is, if there's a discussion around it, can we really figure out a way, like, why would a child under 2 not have this virus? There's no physiologic reason to suggest that. There's some data around the ACE2 inhibitor on the mucosa, but that doesn't necessarily explain why now the numbers are catching up when we're doing more asymptomatic testing. So my point is that we're all going to have blind spots unless we all work together, pool our information, bring together our protocols to really say, like, here are some best practices. And oh, by the way, even though we had a pod system in this school, there's one person who went from pod to pod every day and ended up being positive. So how did we deal with that? How do we prevent that from happening in the future? I think that the group on this call really has the power to inform the rest of the country on safe school reopening.
Thank you so very much, Dr. Razani and Dr. Djavaherian, for joining us today, for sharing your work and your research and your insights. It's incredibly helpful to us all as schools move forward. And I just wanted to add to it at the end that we are presenting this information in the context of we're all imagining that every school will wait until your local health department tells you it's safe to go back, and that when you do, the way to help prevent re-spread is to do the things we're talking about here. We're not suggesting people leap over their health department's advice, and so this is a way, when it's safe to go back, what we'll be doing widely, I think, in the future. So thank you once again for sharing that. We will post a version of the recording on our website, and we would love to include any protocols that or other links that you two recommend, and we will try to answer some more questions in the future as well. So thank you all for your time today and for joining us, and give a big round of applause to our speakers, and a big thank you. Thank you so much.
Thank you guys so much.
What an honor. Thank you for inviting me. Thank you. Thank you, Cesar.
Thank you.
It was really cool to present with you. Bye.
Thanks again.
Thank you both.
Thank you, Sharon, for making this possible too.
And for all who helped during the meeting too. Thank you.